All right, well, good afternoon, everybody. Thanks for joining us today. My name is Margaret Carr, and I'm from NACCHO, and I'm here with my colleague, Nakia Sankova, who's the director of our breastfeeding project. And our talk today is entitled Breastfeeding in the Community, States and Locals Supporting Breastfeeding Together. So just a little outline of what we're going to go over today. We're going to start with who is NACCHO. We're going to talk about our NACCHO breastfeeding initiative. We're going to then look at breastfeeding and public health, and then Title V in breastfeeding, and what now? What are we going to do with all this information that we've learned at AMCHP? So firstly, NACCHO is comprised of nearly 3,000 local health departments, and local health departments are the backbone of the public health system in the United States. As a leader, partner, and catalyst, and voice for LHDs, NACCHO advances the work of local health officials and their staffs to create healthy, thriving communities. So NACCHO values leadership, excellence, health equity, participation, respect, integrity, science, and innovation, and it underpins all of NACCHO's work. These values are reflected in the important work of LHDs, and together, our collective commitment to local public health is improving the quality and length of all lives. So what does NACCHO do? NACCHO advocates for LHDs on Capitol Hill, hosts informative conferences, develops timely tools, resources, publications, disseminates evidence-based practices, provides essential technical assistance, funding, training, and cultivates important partnerships to move local public health forward. And that's why we love to be at conferences like this with our partners at AMCHP. So the Breastfeeding Initiative. We'll be talking about NACCHO's Breastfeeding Initiative, Reducing Disparities Through Peer and Professional Support, which started in 2014. So funding was provided through the Centers for Disease Control and Prevention for a 2-year community-level peer and professional support project. The purpose was to increase the implementation of evidence-based breastfeeding programs, practices, and services at the community level, with a focus on providing peer and professional lactation support to breastfeeding mothers in predominantly African American and low-income communities. And we wanted to develop and maintain public health partnerships critical to building community support for breastfeeding. So we had several goals of this project. One was to increase breastfeeding initiation, duration, and exclusivity among African American and underserved communities. We wanted to increase the implementation of evidence-based and innovative peer and professional breastfeeding support programs. And we wanted to increase local, state, and national partnerships and awareness for the processes, successes, challenges of implementing and expanding local peer and professional support services. So our breastfeeding project activities. In the first 2 years of our breastfeeding project, we identified local health departments and community-based organizations that could implement breastfeeding support programs in their community. NACCHO provided funding, training, technical assistance, and resources to support LHDs and CBO efforts to develop or enhance peer and professional lactation services, expertise, and capacity. We engaged state and local breastfeeding coalitions as part of our local or community level partnerships. We also collaborated with national partners to help lead our activities at the national level, and this is our Breastfeeding Public Health Partnership. And we worked with our breastfeeding public health partners to increase resources and information, improve collaboration and coordination between national efforts, and inform our project activities. And then we evaluate the process and reach of community-level support activities in local communities, and that's why we're here today. We are here to share the lessons we have learned and hopefully inform future work and to improve breastfeeding rates across the country. So a little bit more about our NACCHO grantees. We had 72 awards. Grantees were predominantly community-based organizations and local health departments, but they also included hospitals, community health centers, breastfeeding coalitions, and then we also funded 9 Empower grantees, which is a hospital-based quality improvement program focused on baby-friendly. So our grantees worked with their Empower hospitals in their communities on steps 3 and 10 of achieving breastfeeding-friendly status. Our grantees work predominantly in urban communities, but we had a fair number of communities working in rural or mixed geographic areas. And our grant was targeted at African American women, and 75% of our grantees indicated that their target population was African American women. Overwhelmingly, our grantees documented more than 5 years' experience providing breastfeeding support. So a core component of this funding opportunity was that all organizations provide direct lactation support services to families within their community. That was covered by doing group or individual support. So here you can see some of the different types of support that they provided. They also went beyond direct services and instituted many other activities to engage their communities and do the necessary work. So they included staff training, social marketing to normalize breastfeeding, and actively engaging fathers in their breastfeeding support work. Another key component was building community-level partnerships. So many grantees worked with health clinics, hospitals, home visiting programs. They worked together to conduct community scans, institute telehealth models to support breastfeeding. The list goes on and on. But they were very busy during their 2-year period. They also worked to incorporate lactation services into existing community-based programs, including case management. They also hosted walk-in lactation services in doctor's office or community centers. And they really worked to provide culturally specific breastfeeding resources for their communities. So funding for the project, we had 2 separate funding streams for the core grantees and our Empower grantees. And we had about 20,000 was the average award for our core grantees, and our Empower grantees had about 43,000. And the key thing we wanted to point out here is that they were able to accomplish a lot with a fairly small pool of money throughout their award period. And you can see sort of where their money went. And here are some of our stats from the project. Our grantees had over 90,000 one-on-one encounters. Please note that this is not a unique count of individual women, because often if you work in breastfeeding, a mom needs more than one call or more than one one-on-one or group appointment throughout her breastfeeding journey. And they hosted over 3,000 support groups. And they strengthened over 800 partnerships, because that was another key aspect of our grant. And the context of NACCHO's breastfeeding work, if you'd like to learn more or view any of our trainings, you can visit our website at breastfeeding.naccho.org. And there's also handouts in your tables that give you links to previous webinar recordings and just some more information about the overall breastfeeding project. So now we're going to look just a little bit more broadly at just breastfeeding and public health. So what do we know about breastfeeding? Breastfeeding can moderate the effect of poor health outcomes for mothers and infants across the life course. Infant mortality, infectious disease, cardiovascular, and chronic disease are all public health issues, as we know, and are major causes of death in the US. Most of you are probably aware that the health risk of not breastfeeding. For infants who are not being breastfed is associated with an increased risk of being overweight or obese, developing type 2 diabetes, ear and respiratory infections, and other chronic diseases in adulthood. For mothers, not breastfeeding is associated with increased incidence of type 2 diabetes, heart disease, ovarian cancer, breast cancer, and other poor health outcomes. There is a growing body of evidence that supports that adult chronic disease originates early in life. And while there is some controversy in the data suggests that being breastfed could be considered one of the protective factors against hypertension, obesity, diabetes, and cardiovascular disease. The evidence for breastfeeding mothers, though, are well established, especially for women who breastfeed for longer durations. So in addition to its short-term benefits, increasing breastfeeding duration can have long-term beneficial health effects at individual and population level. Low rates of breastfeeding add more than $3 billion a year to medical costs for the mother and child in the United States, and that's from the CDC. So why don't we usually see suboptimal breastfeeding as a potential health risk behavior along with lack of exercise or poor diet? These overwhelming health risks of not breastfeeding make low breastfeeding duration rates a huge public health concern. So we're going to look a little bit about the disparities in infants ever being breastfed and at different age points. So here you can see we're looking at the national trend of breastfeeding initiation, specifically between non-Hispanic Black and white infants. So if you see the blue circles at the top of the graph, they represent white infants, and the yellow circles along the bottom of the graph represent Black infants. And in 2009, there was a 17 percentage point gap, and the number has varied up and down along the years, and In 2014, it was a 17.7% gap. So basically, no change. Now, if we look at the right side of the graph, we have a comparison of breastfeeding initiation for those at different ends of the socioeconomic spectrum. Again, the rates are increasing, but a persistent gap exists between those at 600% of poverty and those at 100 or below 100% of poverty. So the Healthy People 2020 goal for breastfeeding initiation is 81.9%, and you can see here that, there we go. You can see here that our high-income infants have reached that goal, while our low-income infants have not. So disparities in infants breastfed at 6 months. Again, you can see these persistent gaps in breastfeeding rates, and both of them have gone up since 2009. They've increased. And again, the 6-month Healthy People 2020 goal is 60.6%. So in 2014, white infants have almost reached that goal, and high-income infants have exceeded that goal. But again, our African-American infants and low-income infants have not reached the Healthy People 2020 goals. And finally, for 12 months, the disparities have increased as well. See, going from 9.8 to 16.3, and 12.2 to 19.8. And again, the goal for 12 months is 34.1. And again, our white infants and high-income infants have reached this goal. So what can we do? First, we need to know and understand breastfeeding disparities that exist in our states and communities. And we need to understand that they are not happenstance, but the result of our ingrained cultural, economic, and social system. We looked at the national trends, but it's also important to have state and local data where you can look at these disparities at the community level. To be successful in addressing these breastfeeding disparities, we need to recognize breastfeeding as a public health priority, not as an individual choice that families make in isolation. We need to work with our partners in healthcare, social services, to recognize that breastfeeding has implications for mothers and babies across the life course. We need to work to break down promotion and support silos. Think of all the interactions moms have prenatally and after their baby is born. Is everyone communicating effectively, linking mothers to the appropriate resources in their community? We also need to be engaging the whole family and community to make breastfeeding the easy default choice. We need to work with our state and local breastfeeding coalitions and business partners to break down the systemic and structural barriers that prevent families from reaching their breastfeeding goals. So something we've been working on here at NACCHO is a breastfeeding impact pyramid modeled after Dr. Frieden's health impact pyramid. And the goal is to make breastfeeding the easy default choice for families. So breastfeeding promotion and support efforts focused on individual behaviors are critical for increasing maternal knowledge and self-efficacy. However, without concerted effort to assuring an environment supportive of breastfeeding, the inequities leading to disparities in breastfeeding rates will continue to persist. So at the bottom, we see our socioeconomic factors that definitely influence families' ability to breastfeed. And then our next one up, we have changing the context. How do we make individuals' default decision the healthy decision? We need to ensure that mothers are enabled to embrace breastfeeding as the easy option. They need to have access to paid leave and workplace support, and creating breastfeeding-friendly LHDs and community clinics. Schools, airports, childcare, all of these things can be created in a breastfeeding-friendly way. And then long-lasting protective interventions. Up here, we have donor milk to premature infants, support groups, home visiting, changing the environment, and social norms. And lastly, we have our clinical management and one-on-one education. So these are those one-on-one individual interventions. But really, we need to think about how we're operating at the bottom of the pyramid to really change the conversation and support for families. So now I'm going to turn it over to my colleague Nakia, who's going to do a deeper dive on how Title V and local communities can work together to support breastfeeding.
Thank you. So I talk fast, so let's get a code. Let's make it together so that I can, you can tell me if I start moving too quickly. I get excited. Who's excited about breastfeeding in here? Oh, all right, great. All right. So if I start moving too fast, You guys let me know. Is that a deal? All right, awesome sauce. I will forget at the end, so I'm going to remind you now. Meg pointed out that we put some resources on your table. The blue sheet or the teal sheet is NACCHO's, it gives you some project outcomes. This other sheet is also really important. This is a list of our webinars, and so if you're working in your state or communities and you are working with physicians or nurses or lactation service professionals and they need continuing education, all of our webinars, not all, but many of our webinars carry free continuing education that still is available by looking at the archive. And also with our national partners, we are currently working together to do an ongoing series. Our next webinar is going to take place on March 12th. It's going to be on March 12th. If you go to the NACCHO website that's listed on that sheet, you'll be able to sign up for it. But we also have a sign-up sheet that we'll pass around and make available to you during the Q&A session so that you can get connected with us and get on our listserv so that you will find out about all of our wonderful webinars. So right now we have about, I think, 2,500 people who have received our continuing education through participation. So we're excited about it. And so now let's talk a little bit about Title V and breastfeeding. So as you all know, National Performance Measure 4 is focusing on breastfeeding. And the fact that, okay, I'm about to do the wrong thing. Let me cover this up so I don't mess up. The fact that 49 jurisdictions, states and territories have prioritized breastfeeding as a priority public health issue is super exciting. And it also really means that we're recognizing this as a priority public health issue, recognizing how connected breastfeeding is to a range of long-term maternal and child health and overall health outcomes for the nation. So, as shown, when you all registered, you got a little sheet about breastfeeding from COFECTIV, and it said that National Performance Measure 4, which is associated with breastfeeding, is the second most selected national performance measure, only after well women visits. That's the only other thing. This is largely the case because of the known advantages of breastfeeding are indisputable. The American Academy of Pediatrics recommends that all infants, including premature and sick newborns, exclusively breastfeed for 6 months, as human milk supports optimal growth and development by providing all required nutrients during that time. Breastfeeding strengthens the immune system, and I'm actually not going to go on because I want to make sure that we have time. But Meg already covered a lot of that stuff, and so we know that when we are promoting and supporting the promotion and support strategies that we put in place, many states are implementing multifaceted approaches to improving and increasing breastfeeding rates. These approaches include hospital support, peer and professional support, workplace accommodation, partnerships with existing programs, raising public awareness, and building father-family support initiatives. When I look at some of our former NACCHO grantees, father and family support initiatives were really, really popular. Not only were they effective at reaching a large, a different population of the community whom we normally talk to, but fathers became really engaged, and those are some of my best site visits, going off to see families. And so the Brooklyn Hospital Center partnered with their local breastfeeding coalition, and they included the fathers in their father-to-father program that's run by a male counselor. The Center for Health Equity there in Florida, they had a brother-to-brother program in Alameda County Health Department in California. In conjunction with their FQHE, they trained a male breastfeeding peer counselor to kind of serve as a male champion within their communities, and those are really exciting initiatives. So why am I talking about some of those things? Because those are not the things that we mostly measure. When we look at some of the evidence-based and informed strategy measures that are associated with National Performance 4, and please keep in mind, this is not an exhaustive list at all, right? This is just kind of, when I did a look at what were some of the state-based strategies that were in place, these were the ones that kind of seemed to crop up the very, very most. And so I'm actually not going to read them because they're on the board. It's pretty easy to see, but really the focus was on provider measures, hospital measures, workplace measures, and there's a huge question mark here because there's not as large a focus on what we might call community measures. And so let's think about what might community measures be. We can do some questions and answers at the end. We can think of some things together. But I think that it's also really, really important that we start right now to rethink our framing so that we only are not focusing kind of on these clinical and workplace measures, but we're really thinking about more largely what are we doing in a cross-sectional space in a community paradigm way. So the question is, can these strategy measures, as they were, like I'm not going back, but the one question was the number of providers who were trained. Another one was the number of women who say they received breastfeeding education or their providers talked to them. How many hospitals are baby friendly? Those are some of the measures that were out there. How many workplaces have accommodation policies in place? How many of them have a lactation room? And so one question is, and I wonder if you guys have an answer, do you think that those will help us to, do you think that those measures will help us to decrease the breastfeeding disparities that Meg noted? I think absolutely. Absolutely, I think that they will. And they don't go far enough because those measures don't really look at what are the differences in the different groups. And if we're not really asking the question, if we're not very selectively and specifically measuring what's going on in terms of the differences within the communities that we're trying to reach, then we're not going to be able to get a handle on it. If we only want to know how many of our hospitals had an MPINC score of 89%, or what is the percentage increase in MPINC scores over the last 10 years or something like that, we still won't have a handle on whether or not these are hospitals that are serving the communities that are predominantly low income or the communities that are predominantly minority. So let's kind of think about some ways of which we can begin to think about this work. Oh, okay. So I'm going to go back a slide. So now I'm going to go forward. All right, I have to do it with the clicker. I keep forgetting. I'm supposed to be covering up the paper so I don't use the mouse. So when we begin to think about the provider measures, we know that providers are important. Providers talk to moms through the preconception period, and they talk during the prenatal, postpartum, during well women visits, throughout the pediatric period, throughout infancy, and on through the family care space. And so they're an important, they're a very, very important entity to work with. As we think about them, what things can they do? Breastfeeding support and promotion can be embedded as a standard quality, standard portion of care within their spaces. They can minimize the amount of infant advertisements that are taking place. I mean, how many of you have walked into the doctor's office and you really see infant formula, maybe not even as advertisements, but how much of it is sitting around? Like when you actually go into the room with your infant where it's there and it's available and you can see it. Especially when you work within an FQHC or something like that, very much it happens where, oh, they make infant formula available. Oh, your baby is crying, oh, you need to feed your baby. They're giving out infant formula right there, kind of as a stopgap. And someone says, well, if the baby is hungry and they need milk, well, what are we supposed to do? If mom is here for a 1 hour appointment, now listen to this. If the mom is here for a 1 hour appointment, even if she was there, if the appointment went long and it was 2 hours, and she didn't have formula for her baby, and she had made that choice to formula feed, the issue is not that you need to have formula. The issue is that you need to have some serious connections to social services, because if you've made the option to formula feed and you don't have formula, that's a different problem, right? So minimizing infant formula in doctors' offices, really authentically engaging in cultural humility initiatives to work with your communities, and also developing continuity of care through partnerships and protocols. And so let's give you a few examples of what I mean by that. So what we know in terms of what women have to say about working with providers is that breastfeeding initiation and duration, especially among African American mothers, may increase when postpartum breastfeeding interventions address social and cultural challenges, and when hospital breastfeeding support with the right professional lactation support is void of unconscious bias and bridges hospital and communities, peers, and family supports. Professional lactation training for healthcare professionals who are in contact with expectant and new mothers, and an increase in the number of IBCLCs of colors could really help in these initiatives. So what we know is that some healthcare providers appear to have implicit bias in terms of their attitudes towards white women and women of color, meaning that they don't necessarily believe that women of color are going to breastfeed just because of the statistics that we saw, right? We know that the rates of initiation are lower, the rates of duration are lower, and because of that, what comes first, the chicken or the egg? Black women don't breastfeed, so no, I don't promote breastfeeding as much to black women. So breaking down some of those biases, perception that there is also the perception in the community that healthcare providers are not always fully supportive and sometimes are discouraging of breastfeeding within those communities, right? And so that builds lack of trust in the community, which is why we really have to work on a cultural humility kind of mindset. Very often there's a deep reliance on peers and family as you're making your breastfeeding decisions, and so that makes it seem so, even if your healthcare provider tells you, how many women in here or families in here, your healthcare provider tells you to do one thing, but when you go home, your mother tells you to do something different. All right, that happens, and we know that. And so with that in mind, we really have to make sure that in that cultural space, especially, that providers are aware of that and are taking time with mothers to kind of support that knowledge transfer and understanding where the gaps are happening. And even when that time doesn't exist, one big idea is to make sure that the appropriate resources are available in the offices to cover that gap, even when provider time is not available. And also there's a lack of breastfeeding specific training that happens, which is why one measure obviously was the amount of training that providers have. So there's some links kind of at the bottom of the page. The resources are there, and when you have access to the training, you can get it. So I think that these are some examples from from our breastfeeding project grantees. Monroe County WIC there in New York State, they had a program called Meet Moms Where They Are. They partnered with major Medicaid, OBGYN providers, and pediatricians. They co-located their breastfeeding support and educational support to those clinics, and they integrated these during their appointments by addressing women's known issues. So instead of saying to moms, come over to WIC and get your support, or telling the providers, they worked with the providers and they stayed during certain windows in the provider waiting area in order to engage moms, and the providers partnered with them in that. Esperanza Health Centers is an FQHC, a federally qualified healthcare center in Chicago, Illinois. And they trained all of their providers and their front desk staff to promote breastfeeding and to understand more about breastfeeding. They did an initial survey to kind of understand what was going on and what did people think. And there was a known lack. They established that there was a lack of knowledge and understanding of the importance for breastfeeding, especially at their front desk. They also, through that analysis, began to recognize who was the most appropriate person to provide more intensive lactation supports in that provider setting. And actually, it wasn't the provider, it wasn't the OB, it wasn't the pediatrician, it was the technician who brings you back into the office and does your weight and your blood pressure and stuff. So they focused much of their training with that person in order to, because they have more time with the client, quite frankly. And they established that there would be 9 points of contact for every mom to support breastfeeding. Moms who breastfed past the 6-week mark obviously had more points of contact, but they had 9 points of contact that started during their very first OB visit, and they documented this within their electronic medical record system. And New York State, and I don't know a lot about this one because this is not one of our grantees, but we do know that New York State has a breastfeeding-friendly designation that they have started, and it's pretty exciting because they're working very often with Medicaid providers. And then there's the 9 steps to breastfeeding-friendly healthcare, federally qualified healthcare centers or community health centers, and that's another one. In the same way that I mentioned that when you have a mom who's coming in and she's not having the capacity to feed her baby in that space, then you really have to think, in the same way that hospitals become baby-friendly, different community spaces that interact with women and moms and families can really think about how they can change their practices so that they can also become breastfeeding-friendly. No one else can say baby-friendly, only hospitals. Everybody else can be breastfeeding-friendly. So I'm going to move forward. So what do we know also about hospital support? Very often, everybody goes to the hospital, okay? Not everybody. Almost everybody goes to the hospital to deliver their baby. So it's a critical space, right, to support initiation. And so we're all probably familiar with the Baby-Friendly Hospital Initiative. Also, many states also have local, state-level initiatives like the Texas 5-step, Texas 10-step, North Carolina has one. There are lots and lots of initiatives out there to support hospitals as they are moving from wherever they sit right now to wanting to become baby-friendly. It's a nice, very nice stopgap to support hospitals and to get state-level recognition. And it's great. I mean, in these evidence-based practices, we know, especially when we begin to look at MPINC scores, that there's a recent study, and there's a link there to the abstract, where you can see a recent study that was done by CDC that shows that they broke down MPINC scores into 4 different quartiles, and with each increase in quartile, you saw higher levels of initiation within hospitals. And so we know that effective and evidence-based maternity care practices in a hospital setting really can't change your initiation rate. Initiation is great. Meg talked about all of the long-term health benefits or health consequences of not breastfeeding, and it really wasn't based upon whether or not you ever breastfeed. It's based upon how long and how exclusively you breastfeed. And so while initiation is critical and hospitals are a linchpin in that work, they can't do it alone, right? And so we can continue to measure MPINC scores, but really until we begin to really truly measure how are hospitals truly connecting with communities to ensure care continuity, we're not really doing enough. And so step 3, which is when you look at the Baby-Friendly Hospital Initiative, it's a 10-step process. And so step 3 is talking about prenatal work and doing the prenatal education piece. And step 10 is talking about moving out of the hospital space into the community space. It's very difficult for hospitals to do that on their own. And so also, it's going to be the next slide that has the information I'm looking for. What we know from looking at the data, CDC, this is a CDC data slide, we have really increased the number of infants who are born in baby-friendly hospitals. And although evidence-based maternity care practices that support breastfeeding have been reported to increase breastfeeding initiation, exclusivity, and duration, Black mothers might not have consistent access to these support practices. A study of hospital support for breastfeeding indicated that facilities located in zip codes with higher percentages of Black residents than the national average were less likely to meet the 5 indicators for supportive breastfeeding practices: early initiation of breastfeeding, limited use of breastfeeding supplements, rooming in, limited use of pacifiers, and post-discharge support, which is step 10. Than those located in areas with lower percentages of Black residents. So yeah, we can keep measuring how many baby-friendly hospitals we have. We can keep measuring how many hospitals have initiated, our state-based designations. But until we really start looking at where are these facilities and how are women of color, how are low-income women being supported, then we are still going to see this gap. And so that's where the rubber is going to start meeting the road. And so how are hospitals addressing these disparities? When we look at some of our NACHO grantees and what were they up to, Contra Costa is a health system in California. They're outside of San Francisco. They had a referral system. It says African American referral system. It was just a referral system. Okay, I'm sorry, I missed that. So it's a referral system to really close the continuity of care gap. They recognize, so WIC was our grantee. Contra Costa County WIC was our grantee. They had already done some program with other, because I don't think we said this early on, our project was funded by CDC, the Centers for Disease Control, the Division of Nutrition, Physical Activity, and Obesity. DNPAO has had other funding initiatives working with communities, and in the previous round of funding, Contra Costa WIC worked with different hospital systems within their agency to kind of strengthen their referral systems. And they realized that this one hospital, whose name I can't remember right now, but actually if you look at your flyer, Closing the Care Gap was the first webinar that we had. The CERPs are no longer available, but the CMEs, the CEUs, and the CNEs are all still available for that particular webinar. And they did a full presentation about their project, and also on Closing the Care Gap, Esperanza did a presentation. And they really talked about how even though our funding streams were $20,000, like all of our grantees got about 40 grand because some of them were funded for 16 months at $20,000 a year, and some of them had a much shorter funding period for $43,000 or so. Those grantees that were really most successful are those who had a long-term strategic vision. They weren't starting a project that was brand new with this $40,000. They were building on an overall idea, and they used this money to kind of fill a gap. The gap that Contra Costa had was just this one hospital that largely served African American and low-income women. They didn't have the referral network in place, and so they put it there through this process. They also trained an African American, I think she was already in IBCLC. They had an African American IBCLC that was funded through this project, and she was later, because of the number of referrals that picked up, she was actually hired by the hospital at the end of the day. And so that project, that initiative continues through the funding. Broward Wick was one of the Empower grantees. So Empower was also funded by CDC, DNPAO, and that was their hospital initiative. Part of the decisions about how hospitals were selected was whether or not they were in communities that had or serving zip codes that had high levels of minorities or serving a larger Medicaid population. And so at Broward, they worked and they put their WIC peer counselor. She was supervised, and I'm gonna just be really clear. This thing was a hot mess in the beginning. It was just falling all apart. So that's also a part of the process. It's good to know that. People don't say that. People never say, this was a hot mess. I thought that, I was getting calls from our project officer at CDC, the Empower grantee, they were getting calls from their project officer. Here's the end of the day plan. That peer counselor, they worked through their processes, they found out what the issues were. The peer counselor, post-funding, still is at the hospital recruiting clients on the floor, not labor and delivery. What's happening after labor and delivery? She's on the postpartum floor, thank you. I knew that there was a word, right? She's on postpartum, and she continues to recruit and identify clients. She documents it in the hospital records. She also documents her visit with WIC. She's able to still stay there post-NACHO funds because she identifies so many more clients now that WIC is able to pay her to still be there. And it's a really good relationship at this point. While she's at the hospital, she is supervised by the charge nurse, and it really, really does address a continuity of care issue. And it also addresses the issue that WIC has declining client roles. They were able to identify a lot of clients that qualified for WIC that the hospital didn't even realize that they had that many WIC eligible clients in their client pool. All right, so Meg says that I'm going close on time, and that's fine. Okay, I'm good. I can do this. I have 10 more minutes. We're good. We're still going to have time for questions. So is this making sense to you all about how we really need to rethink some of this data? So in the idea of workplace, we're always talking about, how many businesses in our area have breastfeeding support policies? The real question is, these supportive policies are really important. We need to have pumping rooms, moms need to have private space. It's wonderful to have flexibilities in work schedules and accessible childcare. Do you remember we showed you in the beginning some disparities in breastfeeding rates? So we showed you by race, and we also showed you by what else? Income. Yeah, if you're working in a high-income job, the reality is you're much more likely to have access to these things. 1 in 4 women return to work within 2 weeks of giving birth in the United States. Low-income women return to jobs where they do not have the capacity to pump and are not empowered to speak up about these supports. The educational divide between those who took shorter and relatively longer leave is striking. 80% of college graduates took at least 6 weeks off to care for a new baby, but only 54% of women without a college degree did so. Black women and Hispanic women experience drop-offs in exclusive breastfeeding rates when they go back to work, and Black women go back to work sooner than white women, and this is from a data report from California. So let's look at disparities in breastfeeding exclusivity at 3 months postpartum, right? Because before you can get to 6 months exclusivity, you first got to make it to 3 months. And this 3-month number is going to be most likely impacted by return to work. And so what we can really see when we look at this data is that the gap between Black and white women is growing slightly. It's increasing. And it's almost at 2014 data, and 2014 is the most recent data. This data comes from the National Immunization Survey, and it's retroactively collected. And so even though it's 2018, the most recent data that we have access to right now is for infants born in 2014. There's a 20 percentage point nearly gap in the number of infants who are breastfed exclusively at 3 months between Black and white women, and the gap is 23% between low-income and high-income women. And that's startling, and that has a lot to do with what are the supports available to you when you go back to work. And I go to conferences and I talk to people in different communities, and I always hear what's happening with, like, how can I get these women to breastfeed? They won't breastfeed. It's not that these women won't breastfeed. Let's rethink our language. These women don't have the capacity to breastfeed because the structural supports don't exist. Right? Let's say it again. The structural supports don't exist for these women to breastfeed. And when we continue to talk to Deloitte or other very large companies that employ a largely professional workforce, we are not supporting the women who are low income because that's not where they work by and large. Until we begin to talk to Walmart and Target, and when you go to Walmart and you go to Target, what you're going to find out is they'll say, oh, that's a corporate policy. We can't do anything about that. Then when you go to corporate, they'll say, oh, that's a manager level policy. You can't do it alone as a state health department or even as a local health department. You really, really need to engage community activists at this point to begin to move this work forward. And you cannot put the onus upon the mom to ask for pumping time, because she has to eat, she has to work, and the onus is upon us, the public health workforce, with our allies to support this process, okay? And so, can I do the video? All right, let's see. I want to go into this community.
In the adult world, a food desert is a community with limited access to healthy fruits and vegetables. The USDA says there are 23 million people in the U.S. that are more than a mile away from a supermarket with fresh food. What about babies? They can't eat broccoli or tomatoes yet, and they need access to the healthiest first food for infants, breast milk. But in far too many communities, there is extremely limited or non-existent support for mothers who choose to breastfeed. These places are called first food deserts. In a first food desert, there are 0 easily accessible support groups. 60% of employers do not have a breastfeeding policy for moms. 70% of childcare facilities have not been trained in handling breast milk. Public places where moms frequent, like shopping malls, museums, and airports, don't have a nursing mother's room. There are 0 baby-friendly hospitals within a 35-minute commute. More than 40% of doctors do not offer a lactation consultant referral. There are 0 or too few culturally relevant lactation consultants. And 50% or more of surveyed community members say they would be uncomfortable seeing a woman breastfeed in public. As a result, babies in these areas are sicker than infants in communities where mothers have first food support. Babies in first food deserts have more upper respiratory infections and higher rates of asthma and childhood obesity. And for babies who are born too sick, too small, or too soon, breast milk can literally help save their life. Yet, in first food deserts, too many babies die before their first birthday. Breastfeeding provides health benefits to mothers, too. We want to turn every first food desert into a first food friendly community, a place where all mothers and babies thrive. Join the movement.
That was our little video about community. That was not NACCHO's. I know it was great. I wish it was ours, right? But that was from a different organization. But I think that it's really important to recognize when you look at the measures that your state has selected in order to look at National Performance Measure 4, it's not about hospitals or providers or workplaces. It's all of it. And if you've chosen one, you really need to kind of think back, retrack, and figure out how do they need to kind of interact together. And so community measures or community amalgamated measures are really, really necessary. And in some states, for full credit, some states are really doing a good job at it. So let's talk about, you need supportive policies in public establishments. You need to really shift social and cultural norms. Working with family, friends, and partners, and also with all of the entities that we just talked about, including child care providers. And so Kansas is one example where they have created a communities supporting breastfeeding designation. And actually, I think that is in one of our webinars. Which one? Policy. It's not the policies. It's one of the webinars here that they actually do a presentation with NACCHO. It's the one about states and locals, actually, from national to local initiatives. And I think that one was in January, so the SERPs and stuff are still actually available. So what I like about them is that they are looking at this whole list of things, and they are creating a designation for a whole community, and so that the community can be designated breastfeeding friendly. I think that that's a really, really critical first step. I think it's awesome. I know that North Carolina is doing some work similar in a few of their communities. Can you make a quick guess about what might be the problem? Actually, I'm going to put a pin in that. At the end, during Q&A time, ask me the question of what do I think about what is the pitfall or where does this fall short? Okay? So we also have one of our grantees in Erie County. They were also a grantee of CDC for a different initiative. What I like about Erie County is that they incorporated their breastfeeding goals into their community health assessment, into their community health improvement plans. And I think that this is a really incredible way. Does everybody know what a community health assessment and community health improvement plan is? Who's like, what is this woman talking about? Raise your hand for that one. All right, so everybody knows, good. So with the community health assessment and community health improvement plan, to do your assessment, you have to bring so many different partners to the table anyway to really get a handle of what's going on in that community. States do the same. And it was not tied to increasing breastfeeding rates. The whole thing is tied to really reducing obesity and infant mortality reduction. This is their logic model. I'm not going to go through it because there's a lot going on there, but the point is that they recognize that it's a whole systemic thing that's going to happen. It needs supports and interventions at different places within their community landscape. Public Health Solutions is actually one of NACCHO's grantees, and what I like a lot about Public Health Solutions is that they used all of their NACCHO's dollars to do a very, very large training, and they got special permission to do it because you can't just do training with the money. You have to actually do supports with families, which was one of the goals. But what I like about Public Health Solutions is that the person who was in charge of the funding had supervision over lots of different social support agencies, and she ensured that there was training, that there was changes in their recording system to make sure that every single person that a mom within this community in Queens, I think it was, would have some levels of supports or interactions, and that there would be some consistent messaging across. So when you want to engage your community, you have to ask, listen, partner, do. Ask again. It's a circle. Ask, listen, partner, do. Ask again. Because as you make a move, the system is going to change. The environment will change. And you need to reassess at that point in this new space so that you know what to do next. So, what now? There are many opportunities to engage local health departments and community-based organizations. So, who's coordinating your state, your local, or your cultural breastfeeding coalition? As a state health agency, are you connected to them? What are your communities? What are your opportunities to work with your communities around National Performance Measure 4? In Kansas, they have their community supporting breastfeeding designation, and so they're working directly with their communities to make that happening. What's happening in your state? What's your opportunity? Have you talked to your SACHOs? We're at NACCHO, so some of our partners are the State Association of County and City Health Officials. So how do you connect with your SACHOs around this work, and how can your communities how can you engage communities to increase support for your selected strategies? So there are lots of funding streams out there for breastfeeding. Okay, that's not true. There are not a lot of funding streams out there for breastfeeding. However, there are lots of funding out there for obesity prevention. There's lots of money out there for infant mortality prevention work. And you have this opportunity in this space to figure out how to make these connections. People always say, well, how do I get more breastfeeding money? How do you get more child obesity money? There's a lot of child obesity money. There's a lot of chronic disease and cancer prevention money. Work on that money and stop working in your own little breastfeeding silo, this is your big opportunity. Step out and don't ask for the cancer people or the chronic disease people or the obesity people to come to you. You get to go to them, work on their committees, and get them engaged with you. We had one grantee in the very last webinar on your page. I think it's about policy systems and environmental change. It might be the first one or the last one. I don't know how we ordered it, but Lee County talked about how they were able to work with their state, with their city, I don't know what exactly it was, but they did work to make breastfeeding. They tied it into these larger health initiatives so that breastfeeding could get further support. So it's question time. We're happy to hear from you. We have about 7 minutes.
I want you to answer your question that you posed to us about the Kansas model.
Is it so great I asked you to have that question? Because I forgot about it. I think that one big thing that happens, especially if you're looking at a very large community, with that community supporting, let me see if I can go back to it. With the community supporting agriculture designation, what you will find is that if the community has a number of trained child care providers, they have a leader, they have the coalition engaged. If I look at a community like Washington, D.C., we're all close to Washington, D.C., like and D.C. is actually a pretty small city, right? But when you look at Washington, D.C., there's Georgetown, and then there's south of the river. South of the river is a largely African-American, lower-end, well, D.C. is changing a lot, so I'm not going to say it's largely African-American. It still is, but let's check in 10 years, right? So in any case, these communities are radically different. And so a community like Georgetown, if you apply for this designation using what's happening in Georgetown, you might be able to call DC a community supporting breast. They might get their designation, where there could still be a monster disparity in terms of what's available south of the river and what's available in Georgetown. So the thing is to keep remembering where to look for the disparities.
Hi, my name is Dila Per, and I'm actually with a community-based organization in Washington State, and I have a couple of questions. One is, how do we find out who the grantees are of NACHO so we can find in our state, so we can see how to collaborate with them? I looked, and I couldn't find it on the website. And the second, and this is just a comment as someone who's coming from a community-based organization of 16 people, which is primarily people of color, primarily serving people of color. I'm just curious how NACHO defines community-based organizations, because I think one of our challenges that we encounter as a community-based organization is that many people will like to define themselves as such, but they actually aren't. But often they come in and swoop resources that are really intended for community-led initiatives.
So we are going to be updating our website so that you can have the list of our former grantees. So our funding was from January 2014 through January 2015 through June of 2016. So we currently have no funded communities. That doesn't mean that we don't still have relationships with some of the communities that we did fund. And so in Washington State, we had a community in Tacoma, and that was the only one. And your second question is, I won't say that NACHO defines communities. NACHO predominantly works with local health departments. Those are our members. And we seek to support local health departments in creating space to partner with community-based organizations. I completely understand your perspective. I used to work in Baltimore, well, not quite as small a community-based organization, but in very much the same way, an organization serving communities of color, staffed by people of color. And I think that when I look back at our grantees, the breastfeeding initiative was one of the first opportunities where we funded at NACHO organizations that were not just local health departments, but we also funded community-based organizations. And some of those were one-woman shows. Actually, I'm thinking about Portia in Cleveland, Mommy Knows Breast, I love that name. COBA. No, well, COBA was in partnership with Arkansas Breastfeeding Coalition, but we did fund organizations that were pretty small. It was really based upon the strength of your program. And I think that one thing that we're interested in doing next, and I think that there might be another question I'm going to try to get to, and it's 327, and I will get to it. One thing that we are doing right now, or thinking about and are seeking funding to do, is to work with a diverse set of community players where we bring everybody to the table. So we want to do some intensive, not just training and technical assistance, but really capacity building, where you bring all of the major players, the hospital, the local health department, and a set of community-based organizations with different capacities and different touch points with the organizations, so that we can really kind of do some strategic planning work to understand, because one big thing to think about as you're doing this work is that you have to understand what are the structural barriers in your community. The structural barriers in rural Kansas for people who are largely minority or immigrant women who are largely working in beef factories is very different than what might be happening for a low-income woman in Washington, D.C. or Philadelphia, right? And so you need to really understand what's happening in your own community in doing this work, and so we want to do some capacity building around that, and I think that it really does mean that you need organizations of different sizes and different skill sets and different community connectivity to do that.
So my question is about the data. You mentioned that you had data from the hospital postpartum that went into the WIC system in one of the locations. So I'm curious as to how that collaboration happened, because that seems to always be a challenge. My other question / concern is the data's from 2014 and it's now 2018, and we're always behind in our breastfeeding data, which means we're always behind the curveball. So by the time that we can even reach our women, their babies are a couple years old at this point. So what are the strategies that NACCHO is working with to get better data?
So this is CDC's data, and the data is from the National Immunization Survey. And as I said, the National Immunization Survey is a retroactive study. And so they use the National Immunization Survey as opposed to anything else because it's already a tool that's in use. And I think that I've heard Erica do this exact presentation. The goal is to minimize the burden of tax dollars. Like if you do a whole nother survey tool, it becomes something else. I think that that's national level data, and if you're working in a community, you have different capacity to understand what's happening on the ground in your communities. So you know what's going on. You can get hospital level data to understand what's happening within your hospital systems within a particular state, and I think that that's an opportunity for more real-time data. NACCHO is not, that's not what we do. We don't collect data. So I think that more so what we would do is to help communities, and to the degree that communities are working with states, think about how to access your data. So hospitals have data, WIC has data that's real time, Healthy Start has data that's yeah. And the other question that you had was about, I don't have a better answer for you than that, right? So in terms of the other question about Broward, I think it was about Broward County and WIC. So as a part of our funding stream with CDC, they saw the opportunity to do some collective impact work. And so we had already funded 63 communities with our core round of funding. And CDC at the same time had started funding to APT Associates along with Carolina Global Breastfeeding Institute, and CGBI is our partner within the Breastfeeding Public Health Partners Group. So we looked at what were the Empower hospitals and what were the populations that they were serving, and we reached out to the local health departments that had an Empower hospital in their community, and we did an invitation-only RFA to them so that they could begin to partner directly with those hospitals, specifically on step 3 and step 10. And that is how Broward was able to make the connection to that particular WIC hospital.
I was wondering if you're familiar with the initiative Sisters United or its counterpart Brothers United.
No, I'm not familiar with that initiative.
Okay. I encourage you to look into it. It's Sisters United works with black sororities and works with the graduates of those sororities and trains them in doing outreach regarding breastfeeding, safe sleep, and pregnant women getting flu shots. And they work in their own communities, and this seems to be rather successful at reaching this population. Brothers United came afterwards because of Sisters United's success, and it works with graduates of fraternities. And the idea is that you're not going to have success in breastfeeding unless the male counterpart is supportive in the home. And that's what their focus is on. So if you want to get some information on that, I would email michelle.r.smith@arkansas.gov.
Thank you.
Yeah, they've got a lot of YouTube videos. Good little.
So it is 3:33. Our time is up, but if you have other questions for me that you didn't get to ask, we do have a poster that's going to be in the Skyview area and I'll be there from 3:30 to 4:30, along with Meg, maybe, if she decides to stay with me, and we welcome additional questions. I left my business cards on the table. You can also reach out to us via email. Thank you for joining us for this session.